conference is happening next month, delivered by our stewards and our end-of-life group, very much looking at patient journeys and improving the experience there as well. Finally, I leave you as a board day with this. How will we know we improve? This is our ambition. This is our strategic direction. But thanks to a combination of factors, thanks to Barry and the BI team and others, we now have outcome measures that are all collectible on our business intelligence that we can see in real time. I can tell you how many people are on a register for end of life. I can tell you how many people have been prescribed medicines, have had advanced care planning, or have risk factors that may put them into an end of life category. We have this information now. It's been designed internally, and our new template for FRIDA, which is our frailty marker, can capture all this information as well. So as I close, I want to leave us with the 3 focus areas that we will aim to deliver in the next year. And I will also say that this needs to be underpinned by a competent, confident workforce. Thanks very much, and happy to take any questions on presentation or on the papers.
Thank you, Neha, and then Mark.
Thank you, Matt. That was excellent to see what worked, what didn't work, and how you're taking that forward. One of which, of course, I think you mentioned in this brilliant example, is the absence of the advanced care plan. And now you've mentioned that you can actually see what happens, what is the action, and who actions this thing. You can see that they're not non-existent in cases where there perhaps should be. So what is the next step? Whose responsibility is it, and who makes sure that it's done or not?
It's a really good question. I think part of our journey was to have the shared cared record so that everyone could see the information first of all. The great thing about this FRIDA tool, it is iterative. So in a sense, different healthcare professionals can add to it over time, and it updates in real time. And Anna, you may have some thoughts on this as well, but different people can instigate it as well. So I can, as a consultant on a hotline, instigate this and have authority under my license to practice. Anna, as a GP with her local patients in surgery, could do exactly this, and we use the same standards and the same templates. And our hospice colleagues or our community colleagues can do this as well. Now, clearly there are differences between doctors and nurses, but one of the big bit of work we still need to do is utilise all of our senior resource we have in the system, because at the moment they're still in silos, and we need to be able to pull on whoever senior is around to make sure these senior decisions are made quickly. But Anna, you look like you're desperate to come in here.
Yeah, so great question, Neha. And I suppose my view on this is that it's not one person's job, but because of that, people fall through the net. And I think that's why integrated neighbourhood teams and integrated neighbourhoods working around frailty and end of life are, the way forward. So, in an ideal world, you'd have a team that was looking at all patients that were severely frail or had palliative care diagnoses. They'd ensure that advanced care planning was done, and that responsibility was shared across oncology teams, palliative care teams, hospice nurses, GPs, and sort of PCN-based frailty teams. It's everybody's job, but the coordinating function of a integrated neighbourhood team is the way forward. Yeah.
Brilliant piece of work, by the way, and also it brings out the potential of the EPR too. So thank you.
So Mark, and then Shahina.
Yeah, I mean, it's a great tool. I know we had previous presentations on the tool at previous kind of meetings. My question would be, once someone gets onto the tool, great, then there's that record. How do we ensure that people get on there kind of timely? Again, especially, I know it's different people can put people on, but how do you in some ways minimize the risk of someone not being on there if they're not seeing it for some reason a GP? How can we be comfortable regarding its completeness?
It's a great question. We currently recognise between 40 and 50% of people in the last year of life in this system, but we often recognise them too late. We recognise them particularly in the last month of their life as well. The the ability of population health tools and business intelligence now means that we can risk stratify whole cohorts of patients with certain comorbidities. For example, conditions such as heart failure, Parkinson's disease, dementia inherently give more risk. And for the first time, we can start to risk profile individuals. And as Anna says, that we can then target individuals, as we are planning to do in the next year, with a focus at delivery at INT to think who are our highest risks, and actually then do we intervene. You're right, putting someone on a register does not change your outcome, but we do know that probably indicates that people are thinking about it. Also, I can track all the evidence-based interventions because of this tool now, whereas historically all I could track was a register. Now I can track register plus medicines plus DNAR plus advanced care planning extras. So we have a lot more clinical outcome measures than we ever did 3 years ago.
Thank you, Shahina, and then Emily.
Thanks, Matt. Really, really good. Thank you. Mark's already asked my question, but I'm going to just follow that up, actually. You do mention about people being on a higher risk. How would you identify them and then bring them on board? Is it through GPs? You know, I'm thinking it from a patient point of view.
This is the underpinning with a competent workforce. We've got a big job to do. We've got to differentiate what specialist palliative care is versus generalist palliative skills across the whole medical workforce. That is a huge educational piece, which our clinical leads and stewards are really taking forward, but there's a whole change. And I give an example in secondary care. I'm a Parkinson's doctor myself. It is a chronic debilitating neurological condition, and that it's every clinician's responsibility to recognise when individuals could be entering the palliative phase of disease and plan for that. The key, though, is joined up data sets that this can be done once and entered and the whole system can see, because at the moment it's too fragmented, and then it relies on manual data entry as well.
Thank you. I'm going to take Emily and then Dan and George, and then I need to move us on.
Thanks, Matt, to you and Karen and the whole team for this great all age strategy. And you've touched your example on Mrs. AM, but can you talk a little bit more about the BCYP end of this as well, and supporting children and their families? Because I think, as you said in the kind of paperwork, we're perhaps a little bit further behind in terms of what we can do for them, or at least capturing that impact that you talked about, which I think is really key, recognizing there's probably a huge diversity in the need across BCYP, but it is part of the strategy. So it'd just be great to hear a little bit about that side of it as well.
Yeah, no, thanks, Emily, for the questions. It's really helpful, actually. And we are further behind with babies, children and young people. Obviously, the numbers are just a lot less, as you would imagine. But actually, the services have historically sometimes been fragmented or been centred on one zone within the region. The big move we've taken forward is, A, we've done ambitions mapping with children as well as adults, and B, we've developed a register now for babies, children and young people. The same principle as for adults, so that we can recognise individuals and then plan appropriately as well. It's still very much a work in progress, and thanks, Emily, for reminding us this is a whole age strategy.
Thank you, Dan.
Matt, it's just reflecting on the East of England Palliative Care Conference and my own sort of personal experiences. What's your thoughts about the need for, I guess, what I'd call kind of public education around this? Because nobody prepares you as a family to deal with kind of end of life. And when it comes to power of attorney, those sorts of things, often you only find out about them when it's kind of too late and the horse is bolted, so to speak. And I guess I was thinking around the concept of compassionate communities, and just, do you think we need to do more to, I guess, prepare people that this is the right way to do things, rather than often insisting on that kind of never-ending treatment, because we tend to think everything's fixable, and sometimes the right thing is not to keep doing that. I just wondered what your thoughts were.
And Dan, it goes to right at the heart of the issue, because this is bigger than medicine. This is not a healthcare issue. This is a societal, spiritual, theological issue as well. And death and dying is part of us. And therefore, the hospices have always been very strong in this field as well, around seeing the whole person and the whole family as well. You're right. I think there is a move amongst professionals, but also wider society, to demedicalise dying, to move people away from hospitals to communities, and to empower individuals. Now, the key bit for us I think in healthcare is when scary things happen, often out of hours, and the support is less, we need to be able to provide that wraparound support and advice and guidance when there's dark moments or scary moments, which are expected, but where sometimes people would feel more comfortable in hospitals. So I think part of our strategy is moving people to more communities, but our voluntary sector, and particularly our hospices, play a big role in this as well, but more to go on that.
Thanks, George, and then I must start to move us on.
Matt, your passion is very evident about this. I visited, picking up Emily's point, I visited a children's hospice recently, and difficult place to visit. But I was struck by the cost it takes to run this, and the fact that they have to largely fund a lot of it themselves. And therefore, to give people a good death, we need to make sure as an ICB that hospices are adequately funded. And I guess my question is, have we got that confidence that we've got the infrastructure out in the community to accommodate that? And if we haven't, what do we need to do about it?
I have to declare my interest. I was previously a hospice director as well in a formal life, and very much close to that sector. So hospices, as you know, up and down the country, and this has been nationally recognised, have totally different funding models, from 0% NHS funding, sometimes up to 100% NHS funding. Most are in the 40%, 50% NHS funding zone. They are always vulnerable, but part of the art of a good hospice is because they have voluntary contributions, they can do things in a sense that statutory NHS functions would never be able to deliver. So they have freedom in that. I think positively in this system, we have, for example, with our rapid escalation pathway for those entering the end of life and rapidly deteriorating, that has been commissioned directly to hospices to deliver that on our behalf. That means there is synergy between that whole care aspect of dying, but also the medical input that's required without handoffs and without referrals. It's a big push forward compared to other systems. But if you look at our hospices in our system, all are posting deficits and all having to make difficult decisions. So it's a live issue, it's a national issue, and it's being lobbied by Hospice UK.
Tom is in under the wire.
There's more to build on Matt's response. And so I think one of the areas of work that we do need to look at more generally around the voluntary sector is around the sustainability of the voluntary sector and the levels of funding which NHS and other statutory partners are providing, because I think not just in this space, but we know that there is a level of kind of distress, financial distress being experienced across the voluntary sector at this moment in time, and that presents a risk to our communities. It presents a risk to statutory services as well in terms of the reliance we place on them. So I think one of the things that we've been talking about within the executive team we need to get moving is to start to do some proper thinking and some proper work in that space to understand the risk we're facing and to look at what options we might have to support the sector better and more strategically perhaps than we have done to date.
And I break my own rule. Jeffrey, this is your day job, isn't it?
Yes, it is. And I think it's really big point of distress at the moment, like you said, Tom, and the sector really wants to know what can be done around that. But some of the other thing that you mentioned, has been mentioned in the report, was around kind of the workforce, making sure we have the same workforce. And it says somewhere that they're all kind of part of the people's board, for example. So, and you say all of them are. So can I just confirm that that's true? All of them are in that, being involved. And when they're in the capacity building, training, workforce development, they're all kind of equity there in terms of being involved in the development of those workforces. Thank you.
Yeah, I think Tom, you're going to answer that one.
Joe might want to come in as well a little bit. So I think partially is probably the answer, Jeffrey. So it's probably not as comprehensive as you describe, but it's clearly something we need to think about in terms of the work with the voluntary sector. Indeed, I think at the last People Board, Rue from Hamlin did a presentation, didn't he, around kind of future opportunities and careers in and out between the voluntary sector and the and the health service. So yeah, I think we're on the journey. I don't think we're probably as consistently good at it as we want to be.
Okay, well, I mean, you've got the tenor of views, Matt. It's a fantastic piece of work, and I think too many of us around this table have been touched by the issues that were on the screen there. Just only too many. So all power to you, and thanks to the team behind you that have put this together. And keep us posted on how it's going, please. A tremendous piece of work. So I now need to move on to our next item, which is Mid and South Essex Hospitals NHS Trust compliance with 10 maternity standard. Giles.
Thank you, Chair. And I will take the report as read, but to highlight to board members, every year provider organisations that host maternity services must show evidence of their compliance against the Maternity Incentive Scheme, which is run by NHS Resolution, also known as the 10 Safety Standards. The ICB holds a responsibility to provide a constructive check and challenge to the process, and this year was supported by both a midwifery and also obstetric improvement advisor from the national team. I have obviously shared with the board previously that the trust had achieved all 10 safety standards, but at that time we hadn't concluded the formal process. This is a formal requirement of the board to note the position of the trust, which they have for year 6 achieved all of the 10 safety standards in line with NHS Resolution, and therefore the board is requested to note the content of this for assurance, and should they require to do so, seek further assurance on those standards. Thank you, Chair.
Thanks. Any questions? Matthew, is there anything you wanted to add? No. Joe?
Yeah, thank you, Chair. There is in the detail of the report just a question mark about one aspect of the standard. I didn't know if we wanted to comment on that. I'm not trying to be a naysayer, but there is some detail in there that I'd appreciate linked to workforce, some comment on.
Oh, this is in relation to the neonatal unit, Joe. Yes. So there are some specific standards, which are the number of neonatal nurses that are qualified in specialty. At the time of the conclusion of the report, the percentage had not been reached by the trust. However, as a secondary subset of that, they have to provide evidence of training underway so that they will meet that standard. I can confirm that that training plan is in place. There are neonatal nurses who are in the completion of their qualified in standard, and the trust will meet the standard during this financial year. Therefore, it has met the subset of the standard.
Thanks for the context. Appreciated.
Thank you. Jeffrey?
Thank you. Really good report. Thank you, and well done to MSEFT as well. Yeah. My question is, I mean, it's really good and easy to kind of comply and tick all the boxes, right? So at a very high level question is, to what extent are we actually making this into a real culture change actually as well in terms of the service that's being provided to the people? So maybe one or two things that might just go beyond ticking a particular box. Thank you.
Well, Giles and Matthew, perhaps between the two of you.
So if I answer that, George. So yes, this is the. Sorry, Jeffrey. Sorry, Jeffrey. So yes, this is a formalised piece of work that needs to be undertaken. This only forms part of a huge cultural change that is undertaken in relation to both maternity and neonatal services. At the current time, under our statutory function, we host the local maternity and neonatal system, which really does focus on the views and the experiences of women and birthing people who utilise our maternity services. Within that is a massive culture programme focused on health inequalities, on equity of service provision. Yes, there remain risks, absolutely, and we know that, and referenced in my quality report around ongoing challenges. This trust is not alone in that position, but the sustainable work which is ongoing is closely monitored by the ICB and driven by the senior leadership team within the provider.
Matthew?
Yeah, thanks, Jeffrey. And, as we know, as the saying goes, culture eats strategy for breakfast. And whatever we know that a good, strong culture in any clinical service, in any organisation, can lead to really positive outcomes for patients. It absolutely isn't a tick box exercise. There is real evidence that underpins the scoring. I think that's the key thing to note. This is a good example, I think, this incentive scheme of targeted, hypothecated resource being able to demonstrate improvement in service. And it's something I think that we need to be mindful of. If you resource improvement effectively and you incentivize it effectively, you can actually drive improvement and meeting standards. And I think this was one example where that has been achieved, not just in our organisation, but in many organisations across the NHS.
Thank you. So that is for noting, I believe, yes, and we do indeed note it. And I now move us on to the mental health update. Again, that's you, Giles.
Thank you, Chair. I will take the two reports as read concurrently. And obviously, these reports are sobering in their nature as they refer to two very, very difficult incidents which have occurred. One as an internal report in relation to a mental health provider organisation where there were incidences of abuse of some of the most vulnerable patients in our society, and also the second report in relation to Nottingham, which obviously resulted in the tragic deaths of innocent members of the public by an individual who was suffering acute psychosis. As part of that and following those investigations, ICBs were required to seek assurance from provider organisations that they were responding to the recommendations of either the independent investigation reports or subsequently via NHS England nationally. I will make a point of note, if I may, Chair, that obviously you will see a high-level response by EPUT in relation to the Nottingham report. This is because their full action plan at the time of submitting this paper was going through their internal governance process and being reviewed by their board. I can confirm that that was approved, and the full action plan will be appended to the board minutes and subsequently shared on the ICB website for full transparency, and that has been agreed by EPUT. But you will note that there are a number of recommendations, and certainly in relation to Greater Manchester, both EPUT and NELFT have now responded fully. My thanks to Neha, who, as chair of the Quality Committee, has scrutinised both of these reports prior to coming to board, and therefore I recommend to the board that they receive these reports for assurance, and should there be any further information or clarifications required, we are happy to take those back to the provider organisations. Thank you, Chair.
Thanks. Neha, is there anything you want to add?
No, just that we have, where necessary, we have actually asked for more further updates at the next board as well, even when the item's not due. So
I've no doubt you're onto it. Yeah. So any other questions around this? As sort of as an update, really, isn't it? This we need. Joe.
Yeah, Chair, just quickly. I mean, I do think the reports show both of our providers in a very strong place. I was, a little bit of knowledge in space, and I was very impressed with the report. So well done, everyone.
Thank you. That's good to hear, Joe. Thank you very much. So I'm now moving on to our next item, which is the Health Inequalities Annual Report. And I think, Becky, you're going to be joined by Sophia and Emma.
I am.
Good.
So while
I saw you come in. There you are. Come and I don't know. There must be somewhere where we can accommodate you.
At the end of the table, Mike. Okay. So whilst Emma and Sophia are sitting down, if I just set out a little bit of context. So the paper includes a summary of our health inequalities report for 24-25. As a reminder to the board, but I'm sure we are all aware, health inequalities are preventable, unfair and unjust differences in health across the population and between groups within our society, but also driven by factors that are wider than just simply access to healthcare. Addressing health inequalities is a priority for us as an ICB and has been and will be. It's a key purpose of the ICBs going forward. And our approach has been firstly to look at how we embed health inequalities as a golden thread in everything we do, but also in mobilising some targeted action in those areas of greatest health inequality. So firstly, we'll hand over to Emma to take us through the summary, but just a massive thank you to both Emma and Sophia for their leadership in this space, advocating on behalf of the whole system and really making a difference, which I hope you can see in the report.
Thank you, Emma.
Lovely, thank you very much. So this is the second year that we've produced the Health Inequalities Annual Report, and we've followed the guidance published by NHS England, so looks at specific indicators. Beyond this, we are, as Becky says, looking at how we embed health inequalities in all of our programmes of work, which is actually wider than just what's reported today. It should be read alongside the 25-26 annual report, which sets out how the ICB discharges its legal duties and responsibilities around reducing health inequalities and how that's embedded within our decision-making processes. So tackling health inequalities continues to be at the heart of the ICB. We have at the moment over a 10-year gap in life expectancy between those that live in our most deprived wards compared to our least deprived wards. And we also have inequalities that exist within groups, more vulnerable groups, such as those with people with learning disabilities, people with severe mental illness, and those from specific ethnicity groups. And for our population, that is in particular Black and Asian groups. The report sets out our approach for reducing health inequalities and the actions that are being taken in response to the data that we have been tracking over the last 2 years. We've started to see some tangible improvements over the past 2 years, and those are highlighted in the report, and I just wanted to pull out a couple. So one is the continued increase and uptake of health checks for our vulnerable groups. So those people with learning disabilities and severe mental illness. Not only are we seeing an increase year on year in terms of the uptake, but we are now exceeding national targets, which is positive. We've also, with child oral health, seen a decrease in childhood tooth extractions amongst our deprived community, and that's been a result of a comprehensive programme of work in partnership with our local authorities, schools, voluntary sector, around about Bright Smiles campaign, supervised toothbrushing, improved dental access for children, and supporting the early years workforce. For maternal health, we've seen a significant decline in the smoking rate at time of delivery, and we're now in line with the national target. And for mental health in talking therapies, the outcomes that we see for the global majority are now exceeding those for the white British, and that's through specific actions taken around more diverse recruitment, outreach activities, and the accessible support provided. However, there continues to be a lot of work still to be done. Some of these inequalities, as Becky mentioned, not only strive from health, but are impacted by much wider determinants of health that will take years to address. But we continue to be dedicated towards it and as sustain action programmes. And in particular, there are some areas where we continue to focus around mental health, inpatients, and disproportionate rates of detention among our ethnically diverse populations, and really that is driven by a wide cultural programme of change. As cancer screening, whilst we see improved uptakes in some areas, we continue to need to focus around breast and bowel cancer screening, our most deprived areas, and we're doing some specific engagement work with those patients and the public to understand some of the barriers so that we can start to we continue to take innovative steps to improve their access and their experience. For cardiovascular hypertension, ensuring that those individuals diagnosed with hypertension are effectively managed, and we need to improve that our rates for particularly the younger population and the non-white British, that we have a programme in this year around targeted interventions, working with our GP practices, community pharmacies, and supported by a public health campaign. So hopefully you can see from the report that we have made some strides towards reducing health inequalities. There's a lot more still to do, and we will continue to focus on that in the forthcoming weeks, months and years. Thank you.
Thank you. Sophia, is there anything you wanted to add?
Thank you. No, thank you, Emma, for covering all of that, and thank you for reading the report. I think it was just important to acknowledge that the report really shows that we are making some good progress. There are areas we still need to improve on, but more importantly, is a lot of that improvement is based on a proper joined up, integrated working across the system, and that's something we need to continue to embed. I think looking forward, also thinking about as we go through change, how do we ensure that we keep the momentum that we have gained. We've done very well within the ICB looking at how we are addressing inequalities through our governance processes, and we still need to do a bit more in that area. And continuing to use our population health model tools and insight and intelligence to ensure that we are addressing inequalities and reducing the gap.
Thank you. Sarah, you're new to us and still relatively new to the patch. Reading this, what were your thoughts and feelings?
I liked the report. It's obviously very clearly written. It's just demonstrates some achievements. I think. Oh, sorry. Thank you. I think they're not areas of improvement that we probably didn't know about. They're reflected in other areas, but there's always a lot more to do, and probably more we can do to join up with some of the things that are happening in the local authority around the wider determinants to further support what you're trying to achieve.
Yeah, thanks. Kerry, anything you wanted to say?
Yeah, I was just going to add about the importance of the voluntary sector again in delivering a lot of the interventions, and also identifying communities that we may not know about, particularly new communities, and obviously the role of the local authority. There was going to be another point. Oh, that's right. I was just going to think about obviously the plus groups that were mentioned. I think it's really important to think about unpaid carers as a key group as well. Failure to, obviously they have, a lot of unpaid carers have poor health outcomes, often also, have health as or ignore their health because they're caring for someone else. And I just think that actually we need to actually have that as a particular group to actually focus on.
Yeah, and probably consequence of stress not helping any or all of that too. There's two Emmas, I think, sitting next to each other. Does the other Emma want to say something?
I think just to echo the reliance on the voluntary sector and helping move some of this forward, and also that appreciation that it's not going to be an overnight achievement. It's something we're going to need to continue to invest in as we move forward. I know we're working really hard on that in Southend, and I think we need to do a bit more connecting up to kind of take it further to the next steps, but we're really keen to continue working together as a system.
Okay, thank you, Shahina. Next, yeah.
Thank you very much. A lot of work's being done. I think in terms of the executive summary, what would be really good is to actually say exactly how much change we've managed to get in terms of real data, because if you don't put data in, it's an opinion. So it would be really good to say exactly where we were and where we are now, and how much we've achieved where, and where the challenges are. So there's an overview of it. The other thing that I thought was quite important was that ethnicity on page, which is really quite important, was on page 152. There's a non-stated ethnicity in waiting lists. And that's quite important, really, isn't it? Is there something that we're doing? Is this that the people are not putting ethnicity in?
Yeah, thank you. There is work that is happening in terms of ensuring around the data completeness and accuracy of the ethnicity recording. So this is within MSEFT around whether patients are stating their ethnicity were on referral in and admission to the hospital. So there's certainly more work around the data quality, and in particular we're seeing that in the mental health, child and adolescent mental health services as well. We've identified that's a gap in that service too.
Because it's 20% patients, so it could actually be in ethnic groups here. There are a number of things. I will actually talk to you about it later on, perhaps because of the time.
Well, please do that. It was Joe and then Jeffrey.
Yeah, thanks, Chair. I was massively encouraged by this report, I have to say. I think there's an awful lot of progress in there. Some of it's well quantified, some of it not so quite well quantified. And I think in your summary, Emma, you really hit some of the key takeouts that I got from it. One thing that still shocked me a little bit, which I'd appreciate if there's any further comment on, is those with mental illness, schizophrenia and bipolar, because that statistic of 15 to 30 years is even more shocking than areas of deprivations in excess of 10 and the learning difficulties statistic. So is there anything we're learning around that, and is there anything we can do to do further important work in that area? Thank you.
Yeah.
Oh, I love the innovation with Southend United, by the way. And I say that as a West Ham fan.
Yeah, those life expectancy figures are in line with what we're seeing nationally, which are shocking statistics. The real preventative programme is around, first of all, the undertaking of the health checks to be able to identify not only mental but physical health needs as well. With people with learning disabilities, there are the leader reviews, and they're learning from early deaths to be able to identify some of the drivers and where there were missed opportunities.
What would be nice to hear, Emma, in future is if there's something we can do to make big strides to close that gap. I'd be really interested to hear that in future. Thank you.
Sophia, looked as though you were wanting to come back in on that. You've just turned the microphone off now.
No, sorry, what I was going to say, Emma actually picked up. So it was
okay.
things about learnings from our leader reviews and ensuring that our annual health checks are having a much better uptake and quality also.
So I'm queuing Jeffrey and then I come to Alex. Okay.
Thank you. Good to see you, Emma, and Sophie as well. Really good report. Thank you for that. I think I echo some of the comments made earlier on that, some of it gets a bit descriptive and then some of it is quite data backed. So that's really good. And hopefully we can improve on the bit that we need to do. I'm interested around some of the plus group and the work we are doing with them. So for example, I see that the primary care people are doing a bit more onto the data completeness, for example, 91%, which from what I know elsewhere is really quite good. So I think well done to them. I think my question really is more of a bit more philosophical, I think, than that, which is around, with limited resources, we need to make lots of headway into a lot of ways, different inequalities as well. So is there something around prioritization that may need to be discussed? And would that, where resources may go, would that be in a particular thematic area? Could that be geography, for example? So basically, if we want to do more in certain areas. And that also partly depends on where we think there's a big gap, really, that we must be doing something, which we are not doing. So it's just an open question to invite you to offer some philosophy. Thank you.
So I think that's quite a challenging question. And I suppose this...
He knows that.
I suppose this report is a start of that, in being able to understand where the health inequalities exist, where through our medium-term plan we've set a number of priority programmes, very much trying to embed health inequalities approach within those programmes. So where we have got those priorities, I think the funding allocation, we could get into a whole debate, I think, around primary care funding allocations and being proportionate. We are looking at where other ICBs have taken decisions around allocation of funding in line with more targeted towards need. And so we are trying to learn from what others are doing. So certainly it's in our thought process at the moment. Sophia was.
Yeah, I was also going to say, just echoing what Sarah and Emma and Surya had said earlier, is about this very much being a system approach. So understanding that actually it's not going to be one organisation. So one, there's something about improving our data, and I think we have improved that, and there's still some more data analysis we need to do to understand where the gaps are. But then also actually understanding what each sector is able to do to contribute to closing the gap.
Becky, you wanted to jump the queue?
Yeah, I just was going to just support that regardless of the future organisation of ICBs, health inequalities is still a massive challenge for the populations that we serve, and it will always be all of our responsibilities. And I think, yes, there is something about how do we embed that approach in how we develop strategic commissioning, and what does that roadmap look like. But it is also the opportunities for us to continue the work with local authorities, our DPHs, our wider systems, our voluntary sector is still there, and we need to optimise it.
Yeah, and put another way, no matter what this current transition that we're being required to go through, we must not lose the ability to work together in really effective partnerships with our local authority partners and indeed the voluntary sector for the good of the population we're here for. That is a challenge to us all. Now, I've got a queue. It was Alex and Lucy, and then I'm getting to shut up the shop because I'm already way behind time through bad chairing. Alex.
Try to be quick. Thank you, Chair.
No, carry on.
Just to add on to some of the comments from Joe and Jeffrey, I think there's also part of this work is also taking the communities on the journey with us. So it's about educating our patients and residents about their own responsibilities around their health. And we're doing that through alliances, through local engagement, whereby we're having very difficult conversation with people to say, you understand our position that we're in financially. We can pay for hip replacements, but we might be out of money by the time it comes June or May, whilst we get the budget in April. But then there's responsibility on you to look after your weight, to stop smoking, to consider reducing alcohol intake. And people really, really buy into that. And I think this is where, again, those local connections and really listening to your communities is how we infiltrate and how we make a change, not always with the financial resources, but actually by utilizing the assets that we've got in the community. And just to give some sanity to Joe as well on the mental health front, as my health checks have been a national target for us, this has no longer been the regulation. So it's not forming part of our official plans, but we've taken decision locally to still prioritize health checks and still monitor the data. There's practical activities that are again happening through alliances around this, and that is around how we invite people for health checks. What time in the day is better for them to attend? What do we include in the letters? How do we set up the rooms or the premises where we might want to visit them? So it's really, really personalized care in action, if you like, when it comes to health checks. And just a last point, obviously you'd like to see impact. With prevention, any one of us who has a public health background knows it takes a decade before you see the impact in the numbers. So I would urge you with a little bit of patience as well around some of these numbers, because particularly around the stuff that we're doing with the dental space, it will take a generation before you're going to see those pearly smiles in Thurrock or Southend. But I'm determined that we get there. Thank you.
We've no doubt about your determination, but everyone was nodding as you were speaking there. Lucy, and then I must move us on.
To be honest, I feel like I'd now be repeating what everyone else has said, but it's the one silver lining of the cloud of this consistent change in NHS is that there is a really strong emergent narrative around utilising good quality, complete data to help us identify where need is greatest, allocate our resources proportionately, and embed it not just in single programs of work, but it's going to be about the way we work consistently across all of our pathways. So otherwise, I think anything else added would be a repetition.
Well, Emma, Sophia, Becky, thank you very much for it is a very encouraging report. And we've heard the messages about patience, which unfortunately, when it was doled out by whoever's above us, I didn't get too much off. So other of you around here has got my share of it. You're very lucky. But excellent report. Thank you very much. And I need to move us on. So we now come on to communications strategy, and that's you, Claire.
Thanks, Mike. I have got a bit of a presentation, so you may want to
We'll shift
is in the pack,
ourselves.
but you might want to turn around so you can participate. So I'm pleased to present to you today the impact report for our Q4 communications and engagement activity, which aligns to the communications and engagement strategy which the board approved back in November. Slightly confusing because Q4 is actually the first quarter of the strategy, even though it was Q4 of our financial year. This quarter's seen significant contribution from the team across several strategic priorities, from winter resilience and primary care access to public engagement in the development of the medium-term plan and the national 10-year plan. And we've seen encouraging improvements in staff engagement and media sentiment. The report outlines not only what's been delivered, but also what's been learned, and with a clear focus on continuous improvement and adaptation, particularly in light of the challenges we face going forward within reduction of running costs for ICBs. So this first slide here takes us a quick look through some of the impactful work across multiple campaigns we've run over this quarter. Our winter communications plan drove a 149% increase to the winter hub, where people were accessing advice and guidance around how to support themselves through winter illnesses. And our primary care campaign, in terms of getting the care you need quicker, has seen a boost in NHS app downloads locally by over 22%. So these figures are starting to show the reach and relevance of the campaigns that we're providing to the people we serve, and really kind of embedding that approach that we've taken, in that it's quality, not quantity, of campaigns that we're promoting going forward. The next slide takes a look at some of the internal comms channels that we run across the system. So obviously for our own staff, internal comms continues to be a vital part of the organisational change process that we are going through and will continue to go through over the next 6 months. We've seen high engagement on our intranet, as you'd expect, and particularly the team were able to stand up very quickly a bespoke cost reduction updates section on the intranet that has enabled staff to get a single version of the truth around the change process as and when things are happening or announced. Encouragingly, the latest staff survey showed a big improvement in engagement across motivation, involvement and advocacy for communications across the organisation. On the right-hand side of the slide, sorry, Nick, primary care comms. So we facilitate the primary care hub, which is like an internal intranet for our primary care providers. It's really being consolidated now as a single point of information for colleagues in primary care, particularly around GP practices, but we've extended that scope now to include wider primary care colleagues in pods, so podiatry, optometry and dentistry. And as you can see from the user statistics there, it really is kind of showing really good usage, and people are, the feedback that we're getting from colleagues in primary care is that it's a really useful source of information for them to help support their day-to-day operations. Next slide, please, Nick. So we obviously want to keep learning and evaluate what we're doing. So we held a quarterly pulse poll around the internal comms, and that while 41% of staff do understand our priorities well, there's obviously room for improvement there in terms of how people access information, and we're starting to address this through enhancements to the intranet, but also some of that user-driven content design, so making sure that the people that are using the channel actually have a part in the design of how we present the information. Next slide, please, Nick. So in terms of external communications, we've seen a real big success in the use of Nextdoor, which is a really hyper-local social media platform. And actually, we've done this in tandem with our colleagues in the comms team at MSCFT. We are sharing that platform, so we're making sure that there's consistent messaging going out through that platform to our population. And as you can see from the stats there, there's a huge 400,000 plus impressions, which is, kind of far outweighs the more traditional social media platforms that people expect. Every day there seems to be a new social media platform to get to grips with, and if you're of my age, you kind of stick to the general Facebooks and LinkedIn's, but actually there's growing platforms and channels all the time that the team are innovating and using, and Nextdoor has been a real kind of key success to that. LinkedIn actually, interestingly, remains kind of a really high popular platform for us in terms of a professional point of view, and it's actually a really important internal comms channel for us amongst staff, because we know a lot of our staff access our information through our LinkedIn channel. Our targeted email bulletins, so again, a real big success this quarter has been consolidating our email marketing strategy, and we've seen a huge rise in the number of subscriptions across our email marketing bulletins. A particularly highest growth was in women's and men's health subscriptions, and the open rates remain really high at 44%, which is way and above the industry benchmark in terms of email marketing, so we're really kind of heartened by that. Next slide, and that correlates really with our website analytics. So we've had over 100,000 sessions this quarter on the website. Search remains the biggest driver of traffic to our website, but actually our email referrals, so the links that we put into our e-bulletins, are kind of showing the highest levels of engagement. So once people get there, they're really interested in what they're reading and spending quite a lot of time compared to the average kind of user. So those that come through the emails are spending 31% longer on our website than those that just find it through search alone. Onto media relations. So 26 press releases in this quarter released from us, which generated 92 pieces of coverage for the ICB, 60% of which had a positive tone. And we've had a new editorial partnership in this quarter with The Echo and Newsquest Essex, which has enabled us to reach much more of our digitally excluded audience, making sure that trusted local relevant information is available to a much wider audience than through just digital means alone. In terms of our stakeholder communications, we've seen to growing awareness of our stakeholder bulletins that help support us to get messages through to local political councillors and MPs. And our January briefing saw a 10% increase in engagement from the previous edition. One of our growth areas this quarter has been parliamentary hubs. We've had over 10 just in this quarter alone. But I think that's in light of the fact that we've got quite a few new MPs on the patch. So obviously, as they're getting to grips with the parliamentary conventions, they're learning the ways in which they can get information and ask questions. And that's obviously driven a lot more activity for us in terms of responding to those parliamentary hub inquiries. Public engagement over this quarter has been particularly strong. Our virtual views platform continues to grow, and the people joining that and participating in our surveys and requests for insight continues to grow. We celebrated not yesterday, day before, reaching 1,000 members of our virtual views platform, which is a number we've been chasing for the last couple of months. We did a bit of an email marketing push on that earlier this week, and we got to that magic 1,000 number that we've been chasing. So that was a really good opportunity to kind of celebrate the work that's been done. Some of the areas that we've looked at include blood testing, community hospital services, and actually this is a platform that is open to the whole system. We often provide insight and feedback for all of our providers. We host service on their behalf as well. So it's not just around kind of ICB pieces of work, but across the wider system as well. And then building on that, our research engagement network has been a real success over this quarter. We secured a further £63,000 in funding for our research engagement activities, with now 24 community champions in place across a range of different community and voluntary sector groups that are helping us in reach into their communities of either interest, geography, or demographic. The kind of correlation of that is that more than 12 people have accessed research opportunities in our region because of the work that we've been doing in terms of promoting the opportunities to participate in research through those community champions. And then in terms of the 10-year change plan, we were pleased, and you'll see the kind of insight report attached as an appendix in this. More than 500 people took the opportunity to participate in the engagement work we did around the 10-year plan and our own medium-term plan. And some of that was through the ability for us to support community groups to hold sessions and focus groups themselves, thanks to us securing again a bit of funding through the regional team to help facilitate those meetings and sessions. So in closing, really, I think quarter four, you can see, has delivered some strong results across all of our kind of key pillars in the strategy. We're learning from what's working, particularly in email, media partnerships and grassroots engagement, and we're refining our digital internal comms in response to the kind of feedback we're getting. So just take the opportunity to thank the team for all of their hard work over the last quarter, and to ask the board for any reflections and thoughts in terms of how we move forward into the next quarter, and how in terms we set priorities, because we'll have to reshape our priorities slightly in the next 6 months, given the changes and challenges that we're going through as an organisation. Thank you, Mike.
Yeah, thank you, Claire. Any questions or comments for Claire and implicitly her team on that? I think I've just got one myself, which is I think I've communicated with you about this before, that is there somebody actually checking some of these links as they run through? Because we have a kind of front page with a link that says go there. And I messed around with some of those, pretending to be, you know, not well and seeking help. And I did find some of the paths were slightly circular, in that I sort of was sent back eventually to where I needed to be. Now, that's probably because I'm an idiot and I should have missed clicking the right thing, but surely I won't be alone. And I just wondered if we had some customers who were just doing some of that, then we might just pick that up, because you know, it was really encouraged. I thought this is really good, really good. And when I get there, I mustn't sign up by accident, because I'm not actually suffering from this, if you see what I mean. Are we doing any of that? Can we do any of it?
Yeah. So yes, we are doing some of that. We do have a very active readers panel. So that's a group of lay people that aren't, you know, kind of aren't embedded in the NHS world and language as we are, and they test a lot of our communications approaches for us, and the things that we put in place. A lot of our campaign materials are very helpful in terms of making sure that it reads right. So yeah, in terms of that kind of user testing, we are doing that. There's always scope to do more, and actually sometimes, in terms of those kind of intuitive things that you go around, sometimes it's actually the pathway we commission isn't necessarily the most intuitive either. So sometimes we're reflecting the information that we've got rather than, you know, kind of what would make it easier. But absolutely take that on board, and if anybody does pick up anything like that when then please do flag it to us, and we'll get it sorted.
Okay, so I've got a queue now, which is Pam, Barry, and then Shahina, and then in the interest of time, I'm going to have to move us on. Okay.
I'd just like to thank the team as well. The communications that are supplied to primary care and the work that Kirsten's done with us has been phenomenal over the last 6 months, and the challenges that we've faced. And the team have actually asked me to feed that back to you. So it's really effective and must be retained through the work, the transition that we're having, because that single cascade is something that enables us to get messages out that really change the experience of citizens as they're interfacing with our primary care resources. So thank you.
Thanks. I can't remember who's next, but Barry, you can go first, and then Shahina.
Thanks, Chair. Really great presentation, Claire. Thank you. I guess my question or thought was, when you were showing the different tools, so Nextdoor being the one you've worked in partnership with MSCFT on engagement for, significant place for that flow of engagement with residents and patients. Is there any thoughts about extending that so you have a unified approach across all of the partners for a single platform for engagement?
Yeah, absolutely. So that's virtual views really, and kind of building on virtual views. We're working very closely with both MSCFT and EPUT to try and get them on board to virtual views, so it becomes a full kind of system embedded engagement tool. We're also working actually really closely with primary care. We're running a bit of a pilot at the moment with a PCN around hosting a virtual PPG, patient participation group, for one of the PCNs. So the scope is limitless in some ways with virtual views, but obviously we need kind of the resource and a bit of money from across the system to kind of keep it going and make it work.
Okay, last word, Shahina, on this one.
Claire, thank you so much. I think we've grown, and it's an amazing progress actually, especially in terms of the REN and the work that we do with universities. The openness, the actual research engagement has been amazing. So thank you.
Thanks. Well, much appreciation to the team. Thank you very much indeed. But now I must move us on to Chief Executive's report. Tom.
Thanks, Mike. So I'm very conscious of time. So I think the only thing I really wanted to say is we're in public is that clearly we are working on our response around the running cost reduction for ICBs at this moment in time, with the aim to submit plans to NHS England at the end of May. And so as we move forwards and as we can kind of say more publicly, we will be sharing that with partners and stakeholders and communities as we go along.
Thank you. You've got the body of the report there, which I was assuming everybody's read. Any other questions for Tom? Okay, if not, then thank you, Tom. Much appreciated time saving there. And we're now on to the quality report, Giles.
Thank you, Chair. I'll continue with the time-saving mantra. So I'll take the report as read. Just key things to note that the well-led inspection at MSEFT has now concluded, and colleagues in the provider organisation will be awaiting the initial high-level results from that. Just to say, in relation to the core quality offer during the transitional period, it is important to alert the board that there is now a consultation which has been launched by NHS England in relation to the National Performance Assurance Framework of both provider organisations and ICBs, with a quite rapid turnaround on the consultative process. That will have an impact on segmentation in terms of decision making, and also in terms of the offer of support that will come through from the national team. That work is still underway, in line obviously with model ICB and future model region workforce determinations, but nothing more to add there. Happy to take any questions.
Neha, is there anything you wanted to add as chair of equality? Okay, so any I mean, this is a rolling update, really. Yeah. Okay, thank you very much. We come on now to finance, Jen, and performance in due course as well.
Thank you, Chair. I will take the report as read. I'll just draw out a few key points and give way to Sam to touch on anything for performance that we need to draw out. The board is in receipt of our period 12 or month 12 report. So our year-end accounts are currently going through audit process. So our auditors and our finance teams are deep in conversations around that. We're looking to be able to be ready to submit by June the 20th. So an item we need to pick up in terms of governance and sign off, Chair, if that's okay, at the appropriate point. So just to note that the ICB's financial position at the end of the year was break even, so a very small surplus, but we will refer to it as break even. Our provider partners delivered a collective deficit of 112 million, which, whilst that is adverse to where we plan to be, actually it's a significant improvement on where we thought we could be. If we all reflect back on our trajectories during our run rate trajectory during Q1 and into Q2, we expected that we could potentially be somewhere around the 180 to 190 million mark. So it's been an incredibly challenging time to bring that position back round to where we have landed at the end of this financial year. And I think we have got some lessons learned into the new financial year. I think obviously that has not been without its pain and challenge getting us there. We note that there's been a shift in the ability for us to deliver efficiencies of a recurrent nature in getting to that position, but actually that is something we will be keeping and the board is aware of after we've been through the planning round as well. That is something we were driving hard this year as we focused on grip and control for 24-25. We continue to focus now on our cost improvement programs as we transition to medium-term plan. I think the only other thing I just wanted to note as well is, and it will might be quite a good in spirit of time, is in the financial plan you have the summaries, but what we would like to do is develop our board reporting further in 25-26 so we can focus more on what's important in terms of the run rate. A bit of a laser focus coming at me from the Finance Performance Committee in that space at the moment, but really risk. So I think it's going to be really important. We recognise that there is a risk to delivering our plans, and actually really welcome the board's support in managing those risks as they emerge and helping us to avoid those risks emerging and the impact of them. So we'll continue to develop that work, and I'll, in conjunction with Sam, on the performance aspects.
Well, before we go to performance, we just pause on finance.
Yeah.
So Joe, Mark, or George, anything you want to add around the finance area, please?
Yeah, just building on some of what Jen has said, Chair. I think it's fair to say it was a bit of a heroic end to the year. And Jen rightly raises the concern of the committee on underlying run rate. And I think I've already voiced today the call for a 7% efficiency challenge is huge. So I think we go into a new year very grateful for the huge work that's been done in the last year, and it's recognised as very significant. But the mountains have not got any less steep. So I think I'll leave it there, other than to say we are actively discussing with Jen and other executives and our committee the option, when confidence is such, to try and reduce the drain on executives of monthly meetings. And if we could get to that, I think we'd all see that as symbolic of even more progress. Thank you, Chair.
Thanks. I can't remember, Joe, the demand now for efficiency. Was the best achievement previously? It was 3 point something percent. Was it 3.1 or 3.8? Anyone remember?
I've heard claims of 5%, but never anything.
Really? 5, okay.
I think nationally, Mike, I think it was around 5.8% across the NHS last year, and actually the national average is 7.1%. So the whole of the NHS across England is in this struggle together.
Yeah. Okay, Mark, George, I think either of you want to?
Nothing more to add.
Okay, George.
No, I would just like to commend the finance teams and the governance teams. I mean, we've delivered the annual report. KPMG have done their field work at the moment. I think there's no issues that they're going to raise. It's been a clean audit. Internal controls are good, and really professional work by the finance team, given the fact that some people are going to lose their jobs. They've carried on and delivered, and you wouldn't have seen any change at all. So big thanks to the finance team and the governance team, please.
And indeed, all of our teams, and here around this table, especially Jen, of course. I mean, we've earned, I think, our achievement in terms of the progress we've made. I think probably a lot of us around this table were kind of skeptical of whether we could get there, actually, and we've got to a much better position than we imagined we might, to the extent that we've earned quite a bit of national confidence in the system as a whole. We now have to prove that that confidence is justified. And I've noted Jen's cautionary note, which is that if you're in a tight financial place, one way of sorting things out, and it's only temporary, is to sell the family silver. But you can only sell the family silver once. After that, you have to address the underlying issues, basically. And we've just got to be clear that now we probably have sold most of the family silver. I know that's not finance language, but it will do, won't it?
We'll take it, Mike.
Okay. Great. So now, should we? Oh, please, Alex.
Can I just echo what George said, and on behalf of everyone, really note massive thanks to Jen, because I think it's her leadership that got us through this and got us over the line with the support from FNP. But I think it is hugely recognised how much pressure has sat on your tiny shoulders, as I refer to them, because you have climbed the mountain.
I was 6 foot tall when I started.
I do remember those times, but I think it is the team effort, but it's also the great leadership that you have shown, and the determination of a tiny person with massive tenacity who faced many challenging conversations on behalf of the trust, other colleagues, and everyone else with NHS England. So really thanks to you from all of us.
Okay. Well, we've noted that in that exact language. So excellent. Sam, on performance.
Thank you, Chair. And if Jen was 6 foot tall at the beginning of the year, I'm sure I'm certainly going to be 5 foot by the end of this. So we continue from a performance perspective to operate under strengthened oversight governance across UEC, cancer and elective, supporting our provider organisations. From an urgent emergency care performance, our year-end position is 71% against a target of 78% national target. And from a ambulance perspective, again, just falling underneath that standard of 90%, delivering 81% against that national target. There is continued focus on system-wide coordination to improve the maximisation of our out-of-hospital opportunities in urgent care pathways, which is supported and underpinned by our medium-term plan for this year as well. From a cancer perspective, MSEFT, Mid and South Essex Foundation Trust, continue to remain in National Oversight Tier 1, which is due to underperformance in cancer standards, and again supporting the organisation as a system. The February position saw non-delivery of the national standards for the 28-day faster diagnostics and the 62-day standard. As articulated at the start of the meeting today in terms of the questions, the Cancer Alliance and the ICB are supporting and working with Mid and South Essex Foundation Trust on governance and oversight, specific tumour site focus groups, that's particularly in urology, breast and skin. Thank you very much. Again, ensuring that we can really improve those pathways and reduce those timelines for our patients and come in within the national standards. From an elective perspective, again, the organisation, being Mid and South Essex Foundation Trust, is again continuing on Tier 1 as we move into this financial year. Our year-end position saw us not delivering against our targets, which was anticipated against trajectories. However, again, we are collectively working through initiatives to support demand management in terms of the number of outpatient clinics and procedures, reducing those referrals with community pathways and increasing capacity in insourcing and outsourcing to support the delivery of a zero wait for 65-week waiters at the end of Q1 this year, and 60% delivery of patients waiting no longer than 18 weeks by the end of this year, in line with our operating plan. Thank you, Chair.
Thanks, Matthew. Is there anything you wanted to add to that?
Not materially, Chair, other than to say that as a board and obviously as a leadership team, all hands are on deck to improve waiting times for the people of the county.
Yeah, I mean, we are determined, I think, as a system to get ourselves in a better place, particularly with regard to cancer. Absolutely determined. And we've shown we can do it by concerted effort in money. And so we have to sort of show that we can do it also in cancer, don't we? Matt, were you looking to come in?
No.
Okay. So any other comments on the performance report? Okay, so if not, we've noted that then. Thank you very much indeed. Now on to primary care and alliance report.
Thank you. I'll take the primary care section, and my alliance colleagues will come in on their sections as well. In the expedience of time, we have little left, so I will go through this very quickly.
You're okay, because part 2, I don't expect to take the amount of time allowed for it.
Okay.
But don't take that as a license.
Okay, I won't. So this is the report of overseen by the Primary Care Commissioning Committee, and I would like to extend my thanks to Sanjeev, who's our chair there, who is guiding us through the change period that we find ourselves in, and our responsibilities for primary care, pharmacy, optometry and dentistry, which of course we cover in that committee. We have continued to support access to primary care, and it continues to go in the right direction despite the challenges of local workforce, etc. But the innovative support that the alliance colleagues and primary care team give to those areas means that we continue to drive access up. I'd also like to note and thank Southend Health Watch for their report on Pharmacy First that was noted at the committee. A good report that shows that we're improving access in pharmacy and working in partnership with our doctors, and it's well received by the public, which I think if ever you can relate that to any other things that we've talked about in the committee today, can you get the public on board? Absolutely you can, and that shop window high street presence of the NHS is a real asset to us for future transformation. So we have a new committee set up to ensure that we feed that through to us and to our strategic commissioning of that space. The connected pathway teams are also working on the digital access, and that continues to be a success with that dedicated resource. I think that was recognised in previous parts of the meeting. it's interesting that as a golden thread, of course, primary care is in everything and in every report that we've talked about today. And the integrated neighbourhood teamwork is absolutely dedicated to that frailty and end of life delivery. So what Matt delivered to you earlier in the meeting is being now really honed and delivered at neighbourhood level. So 11 of our integrated neighbourhood teams are absolutely dedicated to frailty, and that joined up piece of work that we've talked about earlier and the benefits that it can derive, as well as another 5 to 6 that are becoming focused on it. So I think that is our strategic move to get a single dedicated approach to those integrated neighbourhood teams and then move on to the next subject area. So lots of work happening in that space. For dentistry, what Claire has mentioned around lots of parliamentary questions, there's a lot of discussion in central government. Oh, sorry, that shows how my stability muscles have worn out. I've got to be prompted by the doctor to sit forward. The dentistry is talked about a lot in central government. We are atypical in Mid and South Essex with the access that we have in dentistry. So much so that we ended up having a session with the Deputy Health Minister last week, and they now wish for us to inform the National Dental Contract Development because of the great work that the team have done. So I couldn't go through a session here without saying that there's a phenomenal response in that health inequality space. They've also started working on cardiovascular opportunistic blood pressure taking, as well as really responding to opening up children and young people's access to dentistry, which I think is a phenomenal achievement from the team in the way that they've worked with the market and shaped it. So I won't say any more about primary care because I could go on about it, and you gave me license, but I'm not going to. So I will turn to my Alliance colleagues to cover the other aspects of the paper.
We'll just pause. Any questions or comments on primary care? Joe?
Just one area, Chair. On the home to assess service, it said that the outcomes expected were not quite strong enough, so it won't move out the pilot stage. But then it goes on to suggest it's continuing in a slightly different form. I just wanted to try and understand that a little bit better, if possible.
Yeah, so that doesn't relate directly to primary care. That's the Better Care Fund and the way that we're working out of areas so in our discharge to assess space, but it's intermediate care as such. But we are working through the reshaping of that with our local authority colleagues.
Okay, I would have thought primary care were involved, but okay, I'll take it offline.
That's fine.
Okay, so now we're moving on then. It's you in alphabetical order here. So is it Dan or you're going first, Becky?
To Becky and Alex.
Just choose.
Well, work out where we're going to start first name. So yeah, exactly. I mean, I think we can take the paper as read, Mike. I think there's just a couple of points that it might be worth just picking up on, particularly because my local authority colleagues are in the room. So from a South East perspective, actually, I think across MSE, we've been submitted the BCF plans for 25-26. So that has been a key part of that work. For South East, one of the critical parts of that for us is our supported enhanced discharge service, and we have been working very closely with our partners for the past year, but going into 25-26 really looking at how we embed and further develop that new model and new service specification, and so that has involved joint commissioning with MSFT, Southend, and it has informed the home to assess service that Joe you referred to and the wider bridging across MSE as well. So I think that obviously in the new world we want to continue to develop and mature those opportunities around joint commissioning. In South East we've also done a really intense piece of work around our primary care estate strategy in Rochford. So we finally launched and I say finally, that sounds very negative, doesn't it? We launched our expression of interest for how we could leverage our Section 106 monies in that area, and hopefully we will move that forward into clear projects that will be mobilised in the next 3 to 6 months, and then as we all are continuing to support the development of INT as part of the approach to our medium-term plan.
Yeah, I like the word finally because it shows some impatience. You see. Who's going next?
But I feel like we've touched on so many aspects of the Alliance work throughout this meeting, actually. So I feel like, without trying to repeat myself, it does feel like it's all about the eyes in Essex, eyes and teeth lately in Essex. So definitely there's a lot of teeth conversations happening in Thurrock, as you know, around young people's agenda. And we've now adopted the eyes and teeth together. So worked with Shahina in making sure that we can use some of that learning into and put it into the eye screening services. So that's the work underway. Thurrock has also engaged with our local health watch around the NHS consultation, and we had a good opportunity to feed back to the NHS consultation around long-term plans, so that we've done again jointly with our local authority colleagues. We continue to engage in a number of workshops around INT, so again looking at our work programme for the year ahead, looking at our priorities, and again unsurprisingly frailty and end of life, of which we talked about earlier, is part of that discussion. Interestingly, in Thurrock in particular, we are a fairly young borough. So for us, the conversation about frailty are earlier and earlier in people's lives. So again, recognizing that, but also recognizing that some people, as we said, don't come onto our radar. So if you will live on a gypsy site in Thurrock, you're unlikely to be registered with any healthcare professional. And this is where the work of INTs and the local connectors is really, really important. Similarly, again, like with Southend, a lot of work around Section 106 utilisation. We are now drafting business case to utilise 200 square metres of free space in Purfleet Care Centre. So that's part of our ongoing commitment to bringing care closer to home. So I think they're the highlights from Thurrock. Happy to take any questions. No football activities, sorry about that. I'll do better next time.
Well, it'd be wonderful to imagine that, you know, one day as that our eye work was getting the recognition that our dentistry work was getting. That would be that there's a performance target for us. That would just be.
I'm only just getting started, Mike.
Okay,
Give me a couple of more
excellent.
years, I'll get there. Shahina and I have got it covered.
Excellent. I can't tell you what she said. Okay, so I mean, always this is work in progress. Oh, Dan, oh dear, sorry. You see, I
to be honest, Mike, nothing needs to be added to what I said. The one formal thing I wanted to note is I think you guys know, we lost Sarah Green as our chair from Farley Hospice. She's taken a year out of work for personal reasons, but Adrian Coggins, who's our public health consultant from Sarah's team up there, has kindly stood in, and the Alliance were very happy for Adrian to take on the chairmanship in the temporary absence of Sarah. Other than that, there's nothing else I need to add to what's already been said.
Are you sure? Because I feel inequity. I should allow you to speak at least as long as Pam.
I'd just be saying what's already been said, so it's fine.
Okay. But I think it's important to note that again, all hands on deck from MIT have obviously been supporting Malden conversations. So again, the staff has been as busy.
Yeah, absolutely. I know everyone's been working really hard. And I was just about to say, I mean, there's still plenty of challenges. We don't live in cloud cuckoo land around this table, but the amount of work that's going on to address those challenges is truly heartening. So thanks to everyone involved. So now we come to general governance issues. There's a whole bunch of stuff to note. I'm only, if any of the committee chairs want to raise anything by exception from those, otherwise we just note them. Thank you very much indeed. We have to delete what?
Sorry.
Oh.
You're on it. No,
Oh.
I thought we'd finish the governance bit.
No, I'm following my instructions here. Yes, we do the annual device of delegating to the audit committee to approve the annual report and accounts, just because of the timetable through which this has to be done to meet national requirements. Are we happy to do that? Yes. Because if not, you're going to be called in for a meeting. Excellent. I've no notice of any other business, so sorry, we've overrun. Thank you very much indeed. That's the end of part one. We say thank you very much to members of the public who've been with us and to those online. And there'll just be now a very short pause, and we'll go on to our part two meeting. Thank you all. Just a very short pause, please.